introducing our next two speakers. Our next two speakers for today have been chosen from among the submitted abstracts. So congratulations to all of the postdocs, fellows, and trainees who submitted your abstracts. Several of those have been selected for podium presentations. Many of them will be shown as posters throughout the day. So our next speaker is going to be Alice Browne, presenting on targeting Hyaluronan-Mediated Stromal Barriers enhances therapeutic response in pediatric sarcomas. Welcome.
Wow, what a feat to follow, Paisley. You're an inspiration to everyone. That was really, sorry, nearly take a minute to compose myself. You're all the buzzwords. You are inspirational, you're beautiful, you're incredible, and you're going to really contribute to the world of science and oncology. Well done. So yeah, I'm Alice, and I'm really excited to present my research where we're targeting hyaluronic acid in the tumor microenvironment and with the potential of improving therapeutic efficacy in sarcoma patients. So pediatric solid tumors are complex environments. They're tumor cells within this tumor microenvironment, which consists of different cellular populations, but also non-cellular elements. And these are collectively known as the extracellular matrix. Now, the ECM is made up of your structural proteins, your collagens, laminins, fibronectins, as well as proteoglycans and hyaluronic acid. Now, if we look at a normal or healthy tissue and organ, we see that the ECM is quite balanced and organized. And this contributes to both biostructural as well as biophysical properties within the tissue. Now, if we compare this to a tumor-associated matrix, we see extreme dysregulation. This results in increased remodeling and deposition of the ECM components and causes an increased matrix stiffness. This then changes the biophysical and biochemical properties within this environment. Now, tumors never do anything unless it's beneficial towards its survival and progression. And there is a lot of known ECM-driven mechanisms that promote tumor survival and spread. If you kind of imagine the ECM and these fibrous proteins creating a cloak or surrounding and encapsulating the tumor microenvironment, it's going to prevent the immune cells from penetrating as well as systemic therapies. It's also known to promote metastasis, angiogenesis, and the ECM can also impact cellular phenotype by directly binding to certain cell receptors, as well through proteolysis, which is the remodeling can reveal different chemokines and cytokines, as well as then through mechotransduction signaling. So the cells are actually able to sense the changes in the matrix stiffness, and this causes downstream signaling changes. So again, if we can imagine this almost, this ECM encapsulating and cloaking the tumor cells, we just thought if we could identify a component within this environment that we could target and degrade, would this enable then better access of immune cells to the tumors and chemotherapies and therapies to be more effective? And that's what got us interested in hyaluronic acid. So hyaluronic acid is a simple linear gag. It's ubiquitously expressed throughout a normal ECM, and it has a lot of really important biological functions. So HA is produced in the plasma membrane by a family of 3 HA syntheses called Has1, Has2, and Has3. They basically make the same end product. For the sake of the talk, it's easier just to imagine it's the same product, so they're kind of interchangeable. But the really interesting thing about HA is that it's secreted directly into the extracellular space. So it doesn't go through your Golgi apparatus, there's no post-translational modification. So if you're a tumor cell and you want to hijack a mechanism that's going to produce and increase this matrix stiffness, the ECM takes a lot less energy for the cell to produce, so it's really easy to hijack. So the first thing we did to see if it was going to be relevant in sarcoma patients was we looked at these HA synthesis expression, and we saw that 50% of patients were presenting with increased expression. It didn't matter which RNA gene, they all were being increased when we compared it to normal tissue and normal adipose tissue, and normal muscle. And again, it wasn't a specific subtype that was driving this. Again, across a broad range of different sarcomas, we were seeing this increased expression compared to normal tissue. And then patients that presented with this increased RNA expression had worse clinical outcome than with patients that had low or none. And then just to see if there was any indication it was driving any cellular function, we took the top genes that were being co-expressed with the increased HASIs, and we just did a gene set enrichment analysis. And what was coming out, we were seeing a lot of the pathways that were known as, the hallmark of cancers pathways or oncogene promoting pathways. These have been significantly increased when you had increased HA. And then because RNA doesn't always translate to increased deposition, we also did staining of patients' tissues. So in soft tissue sarcoma, we saw that tumors were significantly increased. We could visually see HA within these tumors. And again, in osteosarcoma, we were seeing that this HA was physically being increased in the tumors compared to normal bone or bone marrow. And then to kind of just assess if it was having any function on our tumor cells, we cultured osteosarcoma and rhabdomyosarcoma cells with HA and saw that it was able to increase the proliferation ability of these tumor cells, as well as the tumor cells' ability to form colonies. So this all kind of concluded to us that elevated HA in sarcoma patients was a poor marker of prognosis, but it also promoted a cellular phenotype that was consistent with oncogenic phenotype. So then on the opposite side of the spectrum, we decided to look at the hydrolases. Now these are the family of enzymes that degrade hyaluronic acid. And again, when we looked at the RNA expression, we saw that some solid tumors had decreased expression, including sarcomas. And then patients who presented with this decreased expression of Hyal, the enzyme responsible for degrading HA, had worse outcome than patients who had higher expression. So our hypothesis was the sarcoma patients that presented with combined increase of HA and a decrease of the ability to degrade the HA Hyals would have a more aggressive phenotype and worse clinical outcome. So an interesting fact about HA is that it can bind 100 times its own weight to water. So this is really important if you're in your face cream and your filler because it gives you loads of volume, but not in your tumor cell because it creates this real gel-like consistency. It's encapsulating that environment. It's preventing immune cells from coming in and systemic therapies from access to the tumor cells they're trying to target, as well as creating just a really pro-tumorigenic environment that's really has high hypoxia, as well as your pro-tumor growth factors. In addition to that, HA is one of the few ECM components that's directly able to bind to cell surface receptors. One of the most common known one is CD44, and downstream of that you have RAS, PI3K, all again these pro-oncogenic signaling pathways. So our approach was that we could engineer cells that would reduce HA within the tumor. So we chose to use mesenchymal stromal cells, kind of taking advantage of what they naturally do. In their native form, they are ECM remodelers. So what we did was we genetically engineered them to overexpress SPAM1, which is just a really active form of hydrolases. MSCs themselves have homing capabilities, so they tend to home to sites of inflammation, so we felt they would migrate to the tumor site quite effectively. So we got these MSCs that were really capable of degrading hyaluronic acid, and we called them GMSCs, genetically engineered mesenchymal stromal cells. So our thinking was that we would deliver these MSCs, and what they would do is they'd break the barrier, and we'd have better access of systemic therapies, better immune cell infiltration. So the main data I'll be showing you is from our intertibial osteosarcoma model. We chose to kind of first test these GMSCs in this model because it is known to have a high stromal infiltration. Stromal cells are the main ECM depositors, and as you can see here, there is high accumulation of a lot of your ECM components. So it would be, if we could see true remodeling in this, we felt that it was a good indication that it was successful. So our first question, where were the MSCs even going to get to the site of the tumor? So what we did was, again, this is the osteosarcoma model. So we just IP'd injected the cells the opposite side of the tumor-bearing leg. And what we saw was within 30 minutes, they had migrated or trafficked towards our tumor site, and they appeared to have remained there. So we kind of broke down our outcomes into these three that we were going to assess, and just the layout of our experiment was we inoculated our mice, we waited about 10 days until the tumor cells were palpable, and then we harvest the tissue at different time points, and all the results I'll be showing you is 7 days post-treatment. So our first question was, is HA even being reduced? So looking at our HA ELISA, we did see significant reduction in our SPAM-treated cohort, and we were able to visualize this with IHC staining, where you can see that there is significant reduction of hyaluronic acid now in these tumors. Our next question, we wanted to look at another ECM component, so we just looked at collagen. And interestingly, we actually were seeing significant reduction when we did a total collagen assay. And again, when we looked at collagen 1, we were visually able to see this significant reduction. Now, SPAM1 is not enzymatically active towards a collagen, plus in the literature, there was nothing really suggesting that there was this relationship between HA and collagen, where one was decreased, that the other should be decreased. So what we went and did, we did second harmonic generation imaging, and this is a type microscope that visualizes the individual collagen structures, which you see in the blue. And this is a head and neck model because we were able to administer the tumor to the tongue, and that way you could actually image the exact same tumor. So this is the same tumor pre-treated. You see it's like a mishmash, misalignment of your collagen fibers, and then 7 days post-treatment, we see that there's a relaxation of the collagen fibers, they're more linear, and they're we associated with a normal tongue structure. So we were visually seeing that we were remodeling the collagen as well. Next, we looked at immune infiltration, and we saw that our SPAM1 gemesses were able to reprogram immune modulation. So first, we were seeing a decrease in the immunosuppressive myeloid cells, a decrease in exhausted T cells, and then an increase in effector T cells and NK cells. So by simply remodeling or reducing the ECM of these tumors, we now have a reprogrammed and a better immune system at these tumor sites. Again, we were seeing systemic changes in hypoxia, not just on the margin of the tumors, but even in the core. This is a full slide of the tumor. And at the bottom, you can see there's less purple staining. This is a hypoxia probe. So we administered it at 30 minutes before euthanizing our mice. And we can see our SPAM1 treatments has a significant reduction in hypoxia. And we also confirmed this using a HIF1 alpha stain. And then interestingly, we also saw normalization of vascular structures. So the top panel is CD31. This is a mature vascular marker. We saw that this was significantly reduced. And then we looked at CD105, which is more new branching or sprouting vessels, and again, significantly reduced. I call this normalization of the structures because I think there is a negative connotation. When you show that you have reduced vascular, people think, well, treatment isn't going to be able to get there. There's not as much tissue accessibility. And when we did it at Evans Blue assay, what we were seeing was that when these tumors that were treated with our gemesi had actually better accumulation of our Evans Blue dye, which was kind of indicating that there was better accessibility of tissue to therapies. So by degrading the barriers, we have better drug access. So we kind of then concluded that we were remodeling the ECM as well as reprogramming the microenvironment, and that now we had a more immunopermissive vascular normalized tumor microenvironment. But could we take advantage of this therapeutically? So first, when we did this in our osteosarcoma model, we did a single administration of our gemesses, and initially we did see the red line, a reduction in tumor volume. This lasted about 7 days, and then the disease did begin to progress again. So what we did was we repeated dosing every 7 days, and we saw the same trend. Initially, there was a reduction in the tumor volume, and then the disease began to progress again. So now we're trying it with a combination approach. We are using standard of care chemotherapy for osteo. Again, this is the red line, and what we're seeing is when we give cycles of gemesses first, followed by our chemotherapy, it does significantly reduce the tumor volume. We still have to do survival analysis. We are hopeful that we might see a good outcome when we do this for a longer time. And then when we were seeing similar trends in our rhabdomyosarcoma model. So our SPAM1 gemesses were also remodeling the ECM, seeing significant reduction in HA, as well as significant reduction in our collagen content. And again, the exact same we were seeing initially with the dose. We saw that 7-day window where there was a reduced tumor volume, and then the disease did begin to progress again. And again, in our rhabdomyosarcoma model, we were seeing the same trend when it came to immune cell infiltration. And we were seeing a decrease in these immunosuppressive myeloid cells. This is a macrophage marker. And then we were also seeing an increase in T cell infiltration. And in our rhabdomyosarcoma model, we tried taking advantage more of the immune cell modulation that we were seeing, and we tried a combination approach using Cy/Flu. So this depletes the immunosuppressive cells, and then we were giving, with our gemesses, we thought that with the infiltration we were seeing of our T cells and NK cells, that it would help the expansion of them within the tumors. And again, we are seeing promising results. We still have to do a survival, but initially it is reducing the tumor volume, and they are seeming to grow a lot slower. So just to conclude, our SPAM1 gemesi treatment leads to decreased HA, remodeling the ECM. We're seeing changes in the immune composition and reprogramming. We think that our SPAM1 gemesses could be a viable therapeutic approach, whether with chemotherapy or immunotherapy. And our next steps is really to understand the mechanisms of what's happening within this tumor microenvironment and able to really identify the correct combination approach and repeat these experiments for survival outcome. Just want to thank everyone in my lab, and if anyone has any questions.
Reduce the hyaluronic acid, how quickly does that go, and when would you then give your other treatment approach? And I was wondering if you indicated combine it with maybe CAR T cells or something else that doesn't get to the tumor right now.
Yeah, great question. So kind of the first one I showed, we took it at all different time points. We've kind of identified 72 hours is the best time to give the treatment. So we initially give the Gemesi. We see really good remodeling and the infiltration. That lasts between 72 hours and 7 days. The 7-day begins to kind of shift, not fully. So we have been giving our combinations after 72 hours. And as for combining with CAR T, absolutely. I think that side of things will be very important and where we're hoping to move. We are looking at B7H3 CAR T we think we're going to combine with, especially for the osteosarcoma.
Thanks for your talk. Really cool work. I'm curious how this would end up being applied clinically. Can you derive these stem cells from a patient and then engineer and reinfuse?
Yeah, no, the great thing about using MSCs is it's technically an off-the-shelf therapy that you can give allogenic MSCs to different patients. And I think just last year the FDA approved the first MSC therapy in pediatrics. And I think they use bone marrow derived, but it's allogenic off the shelf. So you'd be able to just mass produce them, which is great for patients. It doesn't require that, taking cells and that side of things. Thank you.
Thank you for the talk. With the ECM remodeling, do you think there's any more increased risk of the tumor cells spreading and metastasizing, promoting EMT? Anything sort of?
Yeah, great question. And a lot of people, I think that is the main concern. I think we've seen things definitely when we've targeted collagen that might indicate such things. My research is no, I have not seen any indication of increased metastatic lesions. We are currently doing that a little bit more thoroughly, particularly looking at dormant cells to see if there's anything in different organs. But the interesting thing we think about the MSCs is that in pre-metastatic niches, I didn't show this data, but I've also have noticed that HA is the first ECM component that is increased in your lungs. There's a lot of in these pre-metastatic niches. So we think that our MSCs could also be used to degrade the HA in them niches and prevent a lot of metastasis and could indicate, I don't have data to prove that yet, but just early work is kind of saying that could be an impact factor.
Could you comment on why you think the collagen is also remodeled with the degradation of the hyaluronic acid?
We've been trying to kind of figure that out, and I think it's more that they're sensing that there is, I think in a lot to do in dermatology, there is this indication that, the HA and collagen actually intermingle and combine together. They don't actually bind. It's very weak van der Waals bonds that it is occurring, but we think that potentially when the HA is degraded, the collagen is relaxing. But as well as that, we think that the stromal cells aren't producing, there's not as many CAFs. Potentially, I haven't looked, but we also think that the CAFs may not be producing as much collagen. So it's a combination that without the HA, collagen's relaxing, and then the CAFs are also not producing as much.
And fibronectin, is there any?
Interesting. Fibronectin is a very interesting one. So the percentage of fibronectin within the tumor does not change, but the density through the signal intensity does decrease. So it's kind of indicating that there is less, it's not layered on top of each other. So there could be a decrease in the density, but not the percentage in the cover of the tumor that has fibronectin.
Great.
Hi, good morning.
Morning.
Did you look at any of the non-tumor tissues when you did this to see if there was any effects on collagen or matrix reorganization in any other tissues in the body?
No, we haven't yet, which is, I think, when you're targeting hyaluronic acid, a big concern. The only kind of off-target impact, when we do our IVUS, we aren't seeing them anywhere else, as well as the mice aren't showing any indication of joint discomfort, which a couple of years ago there was a similar clinical trial in pancreatic, and they had to using Ph.D, which is also a hydrogenase, and they had to give quite a low dose because there was difficulty within the cartilage, but we're not seeing that same impact, which we think is due to the MSCs being very localized in their delivery. And just once again, thank you, Paisley. You're such an inspiration. So round of applause for Paisley again.